Good evening, everyone. Welcome to the 65th chapter of IASO Academics Masterclass series. I now welcome Dr. Subrameshwar Rao sir to welcome all of us and kickstart this session. Sir, are you there?
Sir, we are not able to hear you. If you can stop your video, I think we might be able to hear you. Yeah. Yeah. So I think there's some connectivity issues with Dr. Rao. So I think we'll proceed with today's session. We thank ISO leadership, President Dr. Sharad Desai, Secretary Dr. Rudracharya, uh, to allowing us to continue the ISO Masterclass series. The topic for today is gallbladder cancer. We have three wonderful examiners with us who are totally interested and dedicated to this subject. We have Dr. Akash Agrawal, who's a professor in the Department of Surgical Oncology at RML Lucknow. His areas of interest include HPB surgery, surgery for oligometastatic disease, epidemiology, and health economics. He's joined by Dr. Tarun Batra, Associate Professor in the Department of Surgical Oncology at IMS BHU Varanasi. And with them, we have Dr. Swapnil Patel, who's the clinical lead of GI, HPB, and peritoneal surface oncology at the Upkar Cancer Institute, Varanasi. With them, we have two examinees who are Dr. Ravi Teja, who's from Nizam Institute of Medical Sciences, Hyderabad, and Dr. Monil Patel, who's from Bhagwan Mahavir Cancer Institute, Jaipur. A few points to how this webinar would go. The first 60 minutes would be the mock exam, where to our moderator, specifically for today, who's Dr. Swapnil Patel, we would request you to kindly ensure that both of the candidates get equal opportunities to answer. And whenever a question is being addressed, kindly make sure that we point those questions to the candidates by their name so that there's no confusion as to who's supposed to answer. Uh, to the examiners, this is a mock exam. So unlike an actual exam, if they do make a mistake in their answers or they are unable to give the answer to a particular questions, we request the examiners and the moderator to kindly give the correct answer so that the other live participants, myself included, can learn from that question. Uh, for the participants who are joined in, we thank you sincerely for joining in. The best way to attend the masterclass is through live participation because it gives you an opportunity to put in your questions and your queries so that we can utilize this 2 hours to everyone's benefit. To our candidates specifically, if you don't know something, just let the examiners know. They can move on and it will save us time. And keep an open mind, pick up on the hints. With this, we request Dr. Swapnil Patel to kindly load up his screen. We invite the examiners, Dr. Akash Agrawal and Dr. Tarun Batra, and the examinees, Dr. Ravi Teja and Dr. Monil Patel, for the first 60 minutes of this webinar, which would be the mock exam. All the best to the candidates.
Is my screen visible to everyone?
It is.
Yes, sir.
Yes. Yeah. So good evening, everyone. So we'll be kickstarting with the gallbladder cancer masterclass, and without further delay, after a good introduction by Dr. Srijan, I'll just go on to the next. We have 2 to 3 cases prepared, and we'll go through these cases as the time allots and permits us. So we'll begin with the first case right away. I'll give a brief introduction of the case, and then we can start the discussion. So for the first case, we have a 46 years old lady with us, no comorbidities, and who presented to us in the OPD with mild pain abdomen, can say upper abdominal pain, A clinical examination was done at the bedside in OPD, and it was essentially non-contributory. She had come with the ultrasound report already done outside, which was suggestive of a gallbladder polyp, roughly around 3 cross 2 centimeters in size. And then we got chose to do a CECT scan, and which showed multiple polypoidal lesions in the gallbladder without obvious serosal breach or liver infiltration. There was no locoregional lymphadenopathy which was noted, and not much, no distant metastases were appreciated. All other blood investigations were essentially normal. So this is the CCT scan of the representative section of the CCT scan of the patient. So I hand over to the examiners, and maybe we can begin with the questions.
So, yeah, Monil, I would ask you. So, how would you proceed? What do you think about this scan which you're seeing and the brief history Swapnil has just told us?
Sir, USG report mentioned around 3 by 2 centimeter polypoidal lesion in gallbladder, and the CT report suggestive of multiple polypoidal lesion with a serosal breach. Uh, Normally, sir, polypoidal lesion, benign polypoidal lesion does not present with the serosal breach. So this might be this probably a case of a malignant mass in the CAGB, and in this shown image, this is a CECT abdomen, axial image of the CECT abdomen with a distended gallbladder with the uh, mass within the mass lesion, intraluminal mass lesion in the gallbladder. So the I will proceed further with the, and there is no on
Other
the
than
CT
other
report.
than other than serosal breach, what are the other red flags in a polyp of gallbladder where there are
The
more
size.
chances for it to be a malignancy?
First of all, sir, size is the main. It is a 3 by 2 centimeter with the multiple polypoidal lesions. So these are the red flags.
Anything?
Along
Okay.
with
Anything else which is not present in this patient, but will make you think of maybe this polyp is malignant? What is that size after which you will operate a polyp in gallbladder?
more than 1 centimeter size is an indication of sir, elective cholecystectomy, whether if it is a benign or malignant.
Okay, so what are the chances? What are the chances that a polyp of 1 centimeter to be malignant? And what are the chances of a polyp to be of a 2 centimeter polyp to be malignant?
I don't know, sir.
So usually polyps of 1 centimeter, they usually say that chance of malignancy in such polyps is about 5 to 10%. But moment it crosses around, uh, uh, I think 18 mm, that is close to 2 centimeters, the chances rise up to more than 20%. Any other features in the scan which will make you think probably this is malignant? Monil,
Yes, sir.
any other uh, any other signs in the CT scan which will make you think? So see, it's the thickening of the gallbladder wall associated with it,
Uh,
and also a sessile polyp.
hmm.
Usually a pedunculated polyp is not malignant. A sessile polyp which is fixed to the wall and at a broad base is usually malignant.
Okay, sir.
Dr. Akash, if you want to ask anything about,
Yeah. So if I, for the sake of argument, said that this is a calculus, the radio okay, calculus, would you agree with this or not?
Uh, Sir, chances of malignancy in calculus size more than 2.5 centimeter is also high
No,
because
no,
it
no,
led
no.
to the chronic.
No, no. I think you got me wrong. If I said this lesion which you're seeing on the scan is not a polyp, it's a calculus, would you agree or would you disagree?
Uh,
Is it a possibility? Ravi, would you like to answer this?
A possibility will be there, sir, but ultrasound helps in differentiation between the polyp and the gallstone.
Yeah, so that's fine. But one of the easy things to see in this is that the polyp is up. It's not dependent. Stones would generally be dependent. So you can pretty much surely be like, if you see the scan, you can be pretty certain that it's not stone. That's just one of those questions. Yeah, Dr. Batra, you can continue, please.
Okay, in this scan, which other areas, just in this cut, which other areas will you be interested to see in a case of gallbladder malignancy?
Interaortocaval lymph nodes
Right?
and
Anything else?
any surface deposits on the liver,
Right?
any peritoneal metastasis, and here lymph nodes or
Swapnil, can
polyfocal.
you show us? Can he? I mean, he doesn't have the cursor, right? He cannot show it to us. Okay, I don't think so. Okay, can you name a few pre-malignant conditions of gallbladder?
Porcelain gallbladder,
What's the chance of malignancy in porcelain gallbladder?
10 to 15% chances of malignancy.
Yeah, it's around 10%. Anything else?
In primary sclerosing cholangitis,
Yes, yes,
anomalous pancreaticobiliary junction,
right.
in chronic infections like typhoid,
Good, good, good. Anything else?
cholelithiasis.
Yeah, it's not cholelithiasis is not pre-malignant condition, but yeah, it's one of the described etiologies. Okay. Okay, Swapnil, can we have the next? I mean,
So, with respect to further investigations, tumor markers were done for this patient with the hunch of it being malignant, and the tumor markers showed a CA99 levels and CEA levels to be both essentially within the normal limits. And then next, maybe we can discuss about the need for biopsy over here in this case.
yeah. So again, anyone. Okay, Ravi, I would say, what is the significance of CA99?
Baseline, it is not a diagnostic marker, but it helps in follow-up. As a baseline investigation, we will do CA19.9 and CEA.
Right. Do you have any prerequisites before doing a CA99? I mean, of course, not in this case.
Should not have obstructive jaundice.
Right, right. And is it absent in any of the blood? I mean, in blood groups, specific blood groups? It's only for a discussion. Yeah. So it's. And what is the role of CA?
CA is high specificity but not sensitive. It is increased in other GI malignancies.
So tell me a few malignancies where will you get you will get increase in rise in CA.
GI malignancies like colon, rectum.
Okay.
And mucinous cystadenocarcinoma of the ovary.
Right. Anything else?
And mucinous neoplasms of the pancreas.
Okay. One more. Not GI. It's not from GI. Or give me one non-GI malignancy in which you get increased CA.
Medullary thyroid carcinoma.
Right. What's the significance in medullary carcinoma thyroid?
If there is increased CA, it indicates the poor prognosis in medullary thyroid carcinoma.
Yeah, it's basically a prognostic marker. Calcitone is a diagnostic marker. CA is a prognostic marker. Okay. Will you do biopsy in this case?
No, sir.
So how do we proceed then?
Why would you not like to do a biopsy?
As in this case, there is a GB polyp which is not penetrated serosa or liver. So I'll plan for diagnostic laparoscopy in this case. If there are no evidence. FNAC, I'll plan for surgery, sir, in this case. Like,
What's the problem with doing an FNSA? So I agree you want to do surgery, fine. You're a surgeon. But why do you don't want to do an FNSA? Any problem? Because Monil, if you want to ask, if you want to answer, you can answer as well.
even after FNAC also, in this case, I'm going to plan surgery. So better is like surgery or intraoperatively, I will send the specimen for frozen section after cholecystectomy. If there is a positive for malignancy in the frozen section, and I will revise the liver margins.
No, so if I want to be more certain pre-operatively, so I can do an FNSA and be certain about it? No.
So this is with FNSC there is a chance of a peritoneal seeding of the malignancy. So disease will upstage after FNSC, and this
There is
is
a
a
potential. There is a
resectable,
potential for
upfront
spillage.
resectable. Sorry, sir.
There is a potential for tumor spillage, and that is why you would not like to do an FNSC or a biopsy. Generally, if you're planning for surgery.
Okay, you just said you want to do a cholecystectomy in this case. Why do you want to do a cholecystectomy, simple cholecystectomy, when you see a serosal breach?
If there is a serosal breach, radical
You said, right,
cholecystectomy.
there is in the CT scan it's seen.
In this case, I will go ahead with the radical cholecystectomy, sir. But if I want to diagnose before proceeding to radical cholecystectomy, then I will send for frozen section intraoperative.
Okay. Okay. Can we have the next? So, is there any role of FTG PET in this case?
No, CECT thorax, abdomen, pelvis is enough.
Why would you not like to do PET? I mean, we are doing PETs for almost every malignancy. What is the problem with doing PET in this case?
In locally,
Dr. Monil, you can.
Sir, in locally advanced resectable cases, it is advisable to perform PET CT first because there is a 20% stage migration. Because PET can detect the peritoneal dissemination, which is not visible on CT.
Serosal
So,
breach is a T3 tumor,
this
isn't
case,
it?
sorry, sir.
Serosal breach is a T3 tumor?
Yes, sir. T3 tumor.
It's a locally advanced tumor then?
Yes. In this case, there is an indication for PET CT.
What would you do? And that's the thing. You do a PET CT, you won't do a PET CT. Simple.
Yes, sir. Because
Ravi
there
would
is a
not want to
serosal
do. Okay, let's move ahead.
So the next step, which we decided, was to go ahead with upfront surgery, as I think most of us would agree in this case. And then we can discuss certain questions around the role and the conduct of surgery for such a case, which we presume to be probably an early gallbladder cancer. So we can discuss about the extent of surgery, any role of pre-surgery staging laparoscopy, a role of station 16B1 sampling, and do we essentially need a frozen section to proceed with the surgery of this kind, and what is the relevance? And upcoming role of MIS for such a surgery. Examiners, please.
So, Ravi, how will you proceed now? What surgery do you plan in this patient?
First, I will plan staging laparoscopy, sir.
Okay.
If there
Suppose
are
there is no peritoneal disease, no nodules.
Then I will do radical cholecystectomy.
I mean, you'll open the patient straight away after that, or
intra-aortocaval lymph node dissection I will do, and
no,
I'll send.
you've done a diagnostic lab, right?
Yes.
Now there's no disease. Now you want to proceed with radical
Surgery.
cholecystectomy. right? That's what.
Yes, sir.
Okay, so how will you go about it?
Right subcostal incision, and
Right.
then cauterization and intra-cable lymph node dissection. 16B1 lymph node sampling. They'll send for frozen section. If it is a negative, then radical cholecystectomy.
Okay. Okay. How do you proceed? What are your steps for radical cholecystectomy?
Uh, by taking 2 centimeters of the margin around the gallbladder, in the wedge of the liver is taken, and station 12 lymphadenectomy is done. 12A, 12C, 12D, and 12P, and 8A, and 13 posterior pancreaticoduodenal lymphadenectomy.
In this patient, if I would say that I would not want to do a staging laparoscopy and would to just open up the patient, so would you sort of, are you okay with it or you're not okay with it? Munil.
As it is an early stage gallbladder cancer, staging laparoscopy generally gives less yield in early stage cancer. So, if staging laparoscopy facility is not available, we can go ahead with surgery directly in this case.
But a staging laparoscopy is not a very big procedure, so one can do it. It's not, there's no harm in doing it. So one of the questions which Dr. Swapnil put in was, do you need frozen section essentially? Is it mandatory to have a frozen section?
In this case, there is no need, sir, as there is a serosal breach reported in the CT. But if we want to confirm if the disease is T1 or T2 with mucosal thickening or a small polyp within the gallbladder, and if you want to certain that it is malignant CAGB, then we can proceed with the frozen section followed by radical cholecystectomy if it is positive on frozen.
So what all will a frozen section tell you?
Where all will you need a frozen section in gallbladder surgery?
Uh, for level 16B1, another one is the cystic duct stump margin in insidious the CAGB cases to confirm it is negative. Or
And in
if
this
we
case, in the case of polyp, when you have a polyp and you're not certain, or you're sort of slightly okay, it's a malignancy. Would you like, if it was not breaching the serosa, you were not certain, what extra advantage would a frozen section give you in this? Not in this case. In general, if you have a polyp, say at 1.5 centimeter polyp in the gallbladder, uh, then do you think a frozen section would give you any other information which might change your plan?
so patient can be saved from lymph node dissection plus liver resection basically
When? Yeah, you're right. When?
if the frozen is negative.
Or even if it's positive, any condition where you would not want to do a lymph node dissection or a liver resection.
For
Very
T1A
small.
disease.
Yeah. So if it's a very small polyp, if frozen people can tell you that well that it's a T1A lesion, then you can probably make use of it in not doing the full radical cholecystectomy, though that's a pretty rare thing to happen.
So I think we'll move ahead.
Anybody wants to speak about MIS?
So currently there is no study. There is no study showing a role of MIS in radical cholecystectomy.
That's not true. There are studies which are showing and which have shown the role of MIS, but yeah, it's not been accepted as a standard of care yet. But yes, there is growing evidence that yes, MIS is safe and useful, both lab as well as robotic, and there's good emerging data from India as well. So, but then that's it. I think if Dr. Batra is all right, we can move ahead to the next.
Yeah, sure.
All right. So moving ahead. So for this patient, actually I think there was a confusion earlier. The CT did not show a serosal breach in this case, and it was a gallbladder limited disease. So as we were discussing earlier, a simple cholecystectomy was done and frozen section was utilized. Invasive malignancy was shown, as rightly told that the cystic duct margin was negative, inter-aortocaval nodes were negative. So a liver wedge resection was done and a portal lymphadenectomy was completed. And on the final histopathology, it showed it was a T2A lesion and N1 disease and no mets obviously. And roll on discussion around the
One second. Can we just go back 1 minute? I just want to ask. So, any of you, okay, Monul, you tell me. See, this disease on the peritoneal side. Why do you have to take a liver wedge in such cases?
Because sir,
You are anyway good on your margin, even if you do a simple cholecystectomy, right? Then why do you need a liver wedge for such cases? Okay, can you tell me the rationale of radical cholecystectomy?
basically, sir, liver bed contains a small veins plus lymphatic channels that
Right.
can transmit the
Right.
malignancy.
So for any radical resection, you have to take the inflow and the outflow. There is no cystic vein in body, so it drains through the liver bed. That's why you have to take it. And of course, for tumors of the hepatic side, it acts as a margin also. Right. Okay. Okay. Tell me one more thing. Is liver wedge sufficient, or you need? There's a whole debate, or you need a formal segment 4B5 resection.
So if there is a frank sir liver surface involvement, then we have to proceed with the segmentectomy. But if there is no liver surface involvement, then 2 to 3 centimeter margin can be sufficient.
You agree with this, Dr. Akash?
Yeah, I mean, a negative margin is what we are all aiming for. Depends on practice. People, I mean, the basic key thing is that, yeah, what we need is a negative margin.
Yeah.
So
Yeah,
you
the
can do
present
either
evidence is the present evidence is we don't have to do a formal segmentectomy. What you need you can do away with the wedge, but your margins should be clear.
Yeah. The biggest fight is that, I mean, I'll discuss it later in the talk also, that the biggest fight is to get a 2 centimeter margin at the hilum. That's what the whole problem is actually. But yeah, we'll discuss that later. Go ahead, Dr. Tarun.
So yeah, what next now? After you've done it, the histopath says T2N1.
So adjuvant chemo is indicated, capecitabine for 6 months.
What dose?
Forgot. Sir.
No problem. Ravi, would you like to guess?
Dose, no ideas.
Right. So why not gemcitabine cisplatin or gemcitabine oxaliplatin?
Gemcitabine plus cisplatin is also an option, sir.
Yeah. What about adding radiation?
So margins are negative in this case. No, actually, sir, there is no formal liver resection in this case. So there might be a margin positivity.
No.
Because only simple cholecystectomy.
You have done a 2 centimeter margin. You have done a 2 centimeter margin. So that's good enough.
Okay, sir.
Yeah.
Okay, sir.
You have done a 2 centimeter margin. No, it's all right. So you've got, Dr. Sapla picked up for you. It's the liver wedge is free of tumor. So there's no tumor at all in the liver. So it's a T2 lesion. Plus you have a 2 centimeter extra margin. So would you want to give radiation?
No, sir. Adjuvant chemotherapy is sufficient, sir.
Okay. Both of you, none of you want to give radiation.
There is a role of radiotherapy in node positive tumors, but it is a retrospective, so it's not a standard of chemoradiation is also one of the possibility in margin positive and node positive.
So this is a node positive tumor. Would you want to give chemotherapy? Or would you want to give radiotherapy? Add radiotherapy to chemotherapy actually.
But adjuvant chemotherapy is enough, sir. But there are some trials regarding the role of radiotherapy in these type of cases.
You would not want to give. Fine, I think you can move ahead.
Yeah, just for the sake of completion, the dose of capecitabine is, according to BillCap, is 1250 per meter square per dose. So that means the patient receives 2500 per meter square per day. It's divided into doses. But most of our Indian patients are not able to tolerate that kind of a dose. So we give them around 1000 mg per meter square per dose. What's the most common side effect of capecitabine? What will you counsel your patients? Or how will the patient come back to you if he's on adjuvant capecitabine?
And foot syndrome. I mean, blackening of the
Yeah, blackening
almonds.
of. Okay, okay, we'll go ahead.
Go ahead with the next case. So, beginning with the second case, we have with us a 51-year-old gentleman with no comorbidities and was evaluated for plain abdomen and with ultrasonography and was found to have asymmetrical gallbladder wall thickening with gallstones. He was referred to a general surgeon and he underwent laparoscopic cholecystectomy. The surgery was essentially uneventful and the patient recovered well. But the histopathology report showed a well-differentiated adenocarcinoma invading the muscle layer of GB, and we did not have any other further details available in this histopathology report. With this report of cancer, the patient comes to us in the OPD roughly around 6 weeks after the surgery. When he came to us, we began with the usual diagnostic investigations, and the tumor markers done were within normal limits. Blood labs were okay. The slides and logs of the surgery were reviewed, and it showed a moderately differentiated adenocarcinoma T1B. And so we can begin with the questions regarding staging investigations and how further do we proceed.
So, Monil, what is T1B?
So T1B is involvement of the muscle layer of the GB,
So,
muscular
what?
layer of GB wall.
Okay, so suppose if this was T1A, and now, I mean, just hypothetically, so what changes when the tumor becomes T1B? Other than,
Uh,
of course, it's involving the muscle layer. So, what does that lead to?
so basically, the lamina propria does not contain any lymphatic channels, and the muscle layer contains the lymphatic channels. So for T1B, there is a high chance of, 12% chance of lymphatic dissemination of the disease, which T1A
Right.
lacks.
Right. So, what will you do now for this in this case scenario?
Sir, restaging is. I will start with the restaging and do a PET CT, as there is a role of PET CT in insidious CAGB patient to detect the occult metastasis.
Okay.
So what does PET-CT pick up actually?
Basically, sir, if the any intraperitoneal dissemination or
No, which type of
deposit.
pathology? I mean, would it pick up inflammation as well, or would it pick up
Yes, sir.
only
It will
tumor?
pick up inflammation in GB bed, sir, probably.
It could also, and so then how would it be informative in this case? Would it upstage the disease, or would it like? So how do you think a PET-CT would influence in this patient? Patient is about 6 weeks post cholecystectomy. If you had a wound infection, then
Sir, if there is a wound infection, then PET CT is not suggestive, as the whole port side will also pick up the uptake, and this will falsely indicate the port side metastasis. So I will not prefer a PET in case of infection.
how would you know about it? I mean, they might not be a infected wound to see. Actually, they might just be inflammation. or they might it was an infected gallbladder, maybe filled with foreign material. You did a cholecystectomy, so there's a possibility that node should also light up, isn't it? There's a possibility.
Yes, sir.
So do you think you will end up overstaging the patient?
Yes, sir. That might be.
There's a possibility, but as cases very wisely put up, it's at like 6 weeks. So at 6 weeks, you would generally expect almost all inflammation to settle by then. So yeah, one can think of doing it, but whenever you ask for an investigation, you should also look into why you would want what problems it might lead to also. Well, it's not a one-way thing; it's a two-way thing. It might help you; it might also cause you more problems.
Okay, let's go to the next slide. Let's move on.
So the PET CT scan was done and it did not show any metabolically active disease. And so next, how do we plan the further treatment? Do we plan surgery? Is there any need of surgery? Do we go ahead with any neoadjuvant treatment? If surgery, what's the most optimal time? What's the extent of the surgery that we are planning to do here?
Revision surgery. Revision surgery, sir. As there is no evidence of FDG disease in the PET CT scan. And timing, we can do after 6 weeks. I mean, after 3 weeks also we can do as soon as possible. Regarding role of port site excisions, there is no role of port site excisions generally.
So, I mean, suppose if the patient comes to you after, say, 6 months of primary surgery. Same scenario after 6 months. Now what will you do?
Even after 6 months also, if in PET scan, if there is no evidence of any diseases, still I'll consider for revision surgeries.
Say after 1 year?
Dr. Monil?
Sir, I will not consider surgery after 6 months.
Right. I mean, same with our institute. I don't know, Dr. Akash, if you have a difference of opinion on this point. Usually, if the patient presents to us after 6 months, we don't, and it is nothing on PET, then we usually don't offer them any further treatment.
So our patients who generally present to us beyond 6 months are generally not operable, generally speaking.
Yeah, I
But
mean, of course, I agree. I mean, in
that's the
that
bigger
one
issue.
odd patient who'll probably come to you
Yeah.
after
So
six
if
months
one
and
odd patient comes, I think I would err on doing it rather than not
okay,
doing it. This
okay.
is like not evidence-based,
But I
but
agree, I agree. Right, right,
practice-based, because I mean, it's not very infrequent that we have patients who come with recurrences like 2 years after cholecystectomy.
right.
So I'm not certain how useful it's going to be, but probably let's do
Okay,
it.
okay, okay. So what's the ideal time to do this surgery, Monil?
Ideal time is, sir, between 4 to 8 weeks, sir.
Right. But suppose the surgery gets delayed to any which reason, logistic reasons, patient did not get a date, he had to travel. So does it affect the survival in that case?
So maximum we can wait up to 12 weeks, but not after 12 weeks, sir. Surgery is not indicated after 12 weeks of primary surgery.
So you mean to say if the patient comes after 12 weeks, he'll not operate?
Because there is no survival advantage, sir, after 12 weeks.
Okay.
I mean, you're saying that there's no survival advantage of like you. This is like an institutional practice of yours, or is it like some evidence that says that there's no point doing it after 12 weeks?
Uh, there is a paper. I forgot the name of the author, but there is a paper published by author that shows the ideal time for surgery in insidious CAGB patient.
So we
And
understand there's
just
something called ideal time, and then there's cutoff time. Anyway, okay, I think we can move. Uh,
All right.
what
Okay.
what type of
What?
revisions? Please go ahead.
No,
Sorry.
please. I mean, you go ahead. Go ahead. You can.
So what type of revisions, Ravi? What is revision surgery would you do? What will be the components of the revision surgery you would want to do?
Wedge resection of the liver by taking 2 centimeter margin around the gallbladder bed and portal lymphadenectomies.
Anything else you would want to do?
Before proceeding for surgery, staging laparoscopy and intra-aortocaval lymph node dissection and frozen section. If both are negative, then I'll proceed for revision wedge resection and portal lymphadenectomy.
Plus cystic duct margin, sir.
Cystic duct margin.
Yeah, so if you get an opportunity, I think you generally do get. So it's better to excise the cystic duct. So you open the abdomen and there is no disease anywhere, and you find 2 stones in the peritoneal cavity. What do you think it's going to be?
Sir, probably a GB perforation during primary surgery. So there might be a chance of disease dissemination.
Yeah, so that would sort of, make you a little more wary and about the prognosis, and you would like to tell, at least be informed yourself that things might not be as good as you thought. Right? So they might have been bile spillage, right? Okay, fine, I think. Yes.
So, I mean, do you want to know, other than, of course, if there's peritoneal spillage, do you want to know any other information from the preceding surgeon, from the previous surgeon who did the lap cholecystectomy?
Sir, whether he extracted the specimen from by a bag or by simple pulling from the excision port.
Right. So, what is the significance of that?
So there is a chance of implantation of cells if the bag is not used.
So,
For
suppose
extracting specimen.
suppose the surgeon says he's not used a bag, he's just taken it out through the port, say through the hypogastric port, he's just taken it out. So now what you do?
Sir, there might be a chance of port site implantation, but port site excision does not improve any overall survival if at all
No,
there
what
is
will you do? Leave that. What will you do? You have this scenario, exactly same scenario, where the surgeon says no bag was used. Now, will you excise the ports, or will you not excise the ports?
no, sir.
You still not excise the ports. How many patients? Have you read the data? How many of them actually bag the specimen before taking it out in the evidence you are trying to mention?
No, sir.
Is there any such information given there?
I don't know, sir.
I mean, I have read both those articles, and I don't think they have mentioned anything about whether the specimens were bagged or not bagged. And I don't know. Again, yeah, I agree. The data suggests that there is no survival benefit of port excision. But I mean, I don't know, Dr. Akash, what's your take? But we usually do it in case, at least from the retrieval port from where the gallbladder has been taken out.
We generally don't do it as a routine, and but I understand as far as the thing is bagging is concerned, we have patients who have such little and sparse documents that we can, I mean, getting to know
I
that
agree. Yeah, that
a
I
bag has been
completely.
used is not as good as impossible. So
Yeah, I completely agree. I
so
mean,
yeah, if we have the information, well and good, but either way, it will not change our surgical practice to a great extent. So I think we can move to the next question because we are running a little time.
Oh yeah. So in this case, we just did a revision cholecystectomy, and intra-aortocaval sampling was negative, cystic duct margin was negative, and the surgery was done as we discussed. And the histopathology showed a T1B node negative disease and well differentiated cancer, and we did not plan for any further adjuvant treatment. So moving to the third case here with us, we have with us a 56 years lady who presented to us with abdominal pain for 1 month duration and weight loss. There was a palpable mass in the right upper abdomen on a physical examination. However, there was no icterus or any palpable supraclavicular nodes. Blood labs were okay, and tumor marker CA99 was around 80, and CA was 3. And ultrasonography showed, the report from outside showed asymmetrical thickening in the gallbladder wall with liver infiltration. So this is the CT scan, which essentially shows a gallbladder mass with liver infiltration and probably few enlarged lymph nodes, and no other site of disease which was seen. So I think in the interest of time, maybe we'll skip the things which we've already discussed, like biopsy, PET scans, and staging laparoscopy. And probably we can go ahead and discuss regarding the treatment options. Over to examiners.
So yeah, I mean, Ravi, you saw the scan. Now, how will you plan the management in this patient?
In this case, after biopsy, I will plan for NACT, sir.
What are the benefits of giving NACT in this case?
It tells about the biology of the tumor and
Right,
helps in downsizing the tumor, sir.
right. Does it have any survival benefit?
Yes, there is a survival benefit with the NACT, locally advanced CAG.
I doubt we have that information that it has any survival benefit. But yeah, for downsizing and uh, I mean, you may proceed with NACT in such a case. You may not be wrong. Can we do upfront surgery for this case?
No, sir. As a hepatic infiltration, the chances of hepatectomy is needed in this case, which is a morbid surgery for attaining the negative margins. Better is a NACT in this case.
Suppose if the disease doesn't downsize after NACT?
Sir,
Suppose the disease doesn't downsize after NACT.
it means like the biology of the tumor is not good anyway. The patient is not going to perform well.
So you said you would like to give NACT. So your things are you want to downsize, you want to downstage, or you want to increase, increase the better the prognosis, increase survival. Which of these three or which combination of these model would you have in mind when you're planning to give NACT to this patient? Did you get my question? Do you want me to repeat it?
Ask me, sir.
Yeah.
You want me to repeat the question?
No, sir.
If you don't know,
Downstaging the
go ahead.
disease, sir.
You don't downstage. You said stage,
Downstaging
right?
the disease.
So liver infiltration is always a T3. It's 2 centimeters, 1 centimeter, or 5 centimeters. You're not downstaging the tumor, are you?
Yes.
Right. And do you think if you see the scans, was it beyond the realms of 4V5 segment resection?
Very portally.
Didn't appear, at least from that film. So you are not going to, your surgery, do you think your surgery will change after it? Okay. So once you have given chemotherapy and the tumor has shrunk, so how much part of liver would you remove now?
We have to proceed with the formal segment 4B and 5 because
If you're going to do a formal 4V5, you could have done it upfront as well. Why give NACT? So what
sir, mainly,
response
sir,
will it? Yeah, go ahead.
Sir, NACT will mainly give evidence about the disease biology. If the disease is progressive, even on NACT, then there is no role of performing morbid surgery. and we
Is it
can
morbid surgery?
love sir for not morbid but extensive surgery basically. We have to remove a segment 4B and 5 in this case because there is extensive disease is infiltrating much more into the liver parenchyma than into the other side of liver.
So what response, if you know, just answer it. I mean, it's not like a next level question. What response rates do you think chemotherapy has in these patients?
Uh,
Dr. Ravi can also take the question.
Yeah.
50 to 60% response will be
And the
there.
best, and these are like what, stable disease, a partial response, or like PR?
Partial response.
So you have only about 50 to 60%. I would say slightly lesser, but that's fine. So the response rates are not wonderful. So there is a school of thought that says that upfront surgery, if you can do it, why not? I mean, if you're actually now taking away 50% of the patients from undergoing surgery. So that's a way of thinking. What about chemo RT, neoadjuvant chemo RT? Ravi,
Regarding the role of radiotherapy in a neoadjuvant setting, there are some trials, sir, but not. I don't know about the name of the trials, but all these are like retrospective or institutional trials. Institutional. Regarding the role of radiotherapy in the neoadjuvant setting.
Dr. Tarun, you can go ahead.
No, I think we'll move ahead. I mean,
All right.
Move
So,
ahead.
in this
Please.
particular case, as we discussed, we did a ultrasound guided biopsy, which showed a moderately differentiated adenocarcinoma. A PET scan was done, and no distant metastases were identified. We plan to give neoadjuvant chemotherapy, and 4 cycles of gemcitabine and cisplatin-based chemotherapy was given. Response assessment CCT scan showed a partial response, and the patient was then planned for surgery. And I think we have already discussed regarding the role of major resections, and maybe if the examiners find it, we can discuss are there candidates to offer major resection, or if it is to be offered, who is it to be offered to? Should we move ahead?
yeah,
Any one of you wants to take this question, please take it.
Dr. Monil?
Sir, in case of T3, if the other organs such as the colon or duodenum or lab-
So I think I'll break down the question for you. What the examiners want to ask is, do you think there's a role of performing complex surgeries like hepatopancreatic or duodenectomy for locally advanced gallbladder cancers or multivisceral dissections?
if we can achieve R0 resection, then there is a role. If the R0 resection is not possible, then this type of major surgeries are futile.
Dr. Ravi?
In good performance status patients and no comorbidities, good response to chemotherapy, there is a role of hepatopancreaticoduodenectomy, but better is to avoid two major surgeries like hepatectomy alone or pancreaticoduodenectomy alone is okay, but combining hepatectomy with the pancreaticoduodenectomy for a CAGB, it's like a T4 disease. Anyway, they are going to perform bad in future. Like so, doing hepatopancreaticoduodenectomy is not a good option.
So, Ravi, can you tell me what is how do you define a major hepatectomy as?
Extended right hepatectomy.
So if I remove segment 4B and 5, would you call it a major hepatectomy?
No, sir.
How many segments do you need to remove to call it a major hepatectomy? Monil, would you like to take this?
No, no ideas.
If you remove more than 3, then it's called a major hepatectomy. Just starting to.
When will
So
you do
let's
a
remove.
hepatic duct resection? I mean, when do you do a extrahepatic bile duct resection?
For cystic duct margin is positive in the frozen section, or if there are any lymph nodes adherent to the CBD which are not separable, then there is a role of extrahepatic biliary tract excisions.
Suppose if the patient was jaundiced.
Better is to do dryness pre-operative.
Better is to do?
In obstructive jaundice patient, better is to do drainage, ERCP drainage, or if there is no, if hilum is patent, a BRCP drainage is better, or PTVDs.
No, of course, it's better, but suppose after NSCT, if this patient comes up for resection, you need to resect the bile.
If nodes
Okay,
are
we can.
not adherent to the CBD, then radical cholecystectomy is enough.
Okay. Okay, I think we can go ahead, Swapna.
So I think we are done with the 3 cases. We have a fourth one. It's already 8. Do we have the time to go ahead with the fourth case?
I think we can extend till 8:10, Dr. Swapnil. So
All
if
right.
we can quickly just
All right.
wrap
Okay.
it up. Yeah.
So I think I'll go quickly through this case and discuss just the important points. And this is a 70 years lady, comorbidities in the form of diabetes and ischemic heart disease, and it was evaluated for jaundice of 20 days duration, and the total serum bilirubin level was 14. Alkaline phosphatase was also raised, and counts were okay. INR was okay. CA99 was raised, and an ultrasound report showed a GB fossa mass with infiltration of the liver and bilateral IHBRD and intrahepatic biliary radical dilatation. And a CT scan again confirmed the same and showed a GB fossa mass with hepatic infiltration and bilateral IHBRD and periportal nodes. However, no distant metastases were noted. So I think I'll run through the CT scan. We have the video in this case. I'm not sure if we can. So, there's a problem with the video. So, anyways, further investigations. How do we proceed with this lady? And the examiners can proceed with the questions. We have a gallbladder mass with biliary infiltration with IHBRD. Examiners and the candidates, please.
So, yeah, Ravi, tell me, how will you go ahead?
In this case, ERCP drainage
Right.
to relieve the jaundice, and after that, I'll repeat the CA 19.9. And as there is a periportal lymph nodes in this case, I'll take FNAC from the GB mass. I'll consider after relieving of jaundice, I'll consider by sending patient to the neoadjuvant chemotherapy.
Usually, how much should the bilirubin level be for you to give neoadjuvant chemotherapy?
6. No idea. Exactly, no ideas.
Dr. Monil, will you like to read the question?
No idea, sir.
So, anything less than 3, you can go ahead with neoadjuvant chemotherapy. How much time will this? What was his? Swapnil, if you just show the previous slide, what was the bilirubin?
14.
14. Usually, how much time does it take for bilirubin to normalize after obstructive jaundice?
Up to 21 days, sir.
So, irrespective of the level, suppose it was 40 and this is 14. So what is, I mean, if I make it simpler, very simple, I'll make it. What is the half-life of bilirubin? So basically, bilirubin binds to albumin, which has a half-life of 20 days. So now you can calculate around 4 half-life, that much it will take for it to come to near normal levels. Okay. If we
I
can,
think Dr. Swapnil is losing connection. He'll be joining like in 2 minutes.
sure.
Yeah. I really request the candidates to answer to the point, and if you do not know immediately, just declare that you don't, and we can get the right answer, and it will save us a lot of time.
So what type of stent would you like to use? Would you like to use plastic stent or would you like to use a metallic stent? What are the benefits, pros and cons of both? Ravi, would you like to answer this?
Plastic stents, sir.
Why?
Because at the time of surgery, it is not going to interfere. If we use a metallic stent, there will be difficulty in extracting the stent.
But, but then a metallic stent would not block, and it will possibly lead to resolution of jaundice as well, isn't it? But fine, we'll use a plastic stent. I go with you. Monil, if I said I wanted to do a PTBT, would you agree? Would you disagree? What are the advantages and disadvantages of a PTBT vis-a-vis ERCP?
Sir, in this case, the obstruction is due to the periportal lymph node compression. So the ERCP option will be better than the PTBT because the internal drainage can be possible and chances of the complication.
What is the major complication of PTBD?
Major vessels injury during the cannulation.
Mhm.
Not major vessel, but uh, ch- chances
So
of the
have you seen patients with PTBD?
actually, sir, I have not seen someone to performing PTBD.
Okay. Ravi,
I
have
have
you seen
seen patient
patients
with
with
the
PTBD?
Yes, sir. Tube block or tube migration will.
Yeah. So one of the biggest problems with PTBD is that it's one non-physiological because all the bile is coming out, it's not going into the gut. Secondly, it's very frequent for pulled PTBDs and sepsis to happen because of repeated reinsertions. So this can be a problem. So Swapnil is back. Swapnil has reduced the bilirubin to 2 after 2 weeks. So
One,
what would
one
you
more
like to do
question
next?
I just want to ask. How do you
Yeah,
diagnose
please.
stent block? How how do you come to know the stent is blocked?
bilirubin levels are not decreasing.
Say from 14 they came to like 5 and now they've become 7. So
It might be due to the stent blockage, sir.
anything else? Okay, bilirubin, once it has gone down, it's probably coming up again. Anything else?
Dr. Ravi?
So the two things, basically, the
Cholangitis.
alkaline phosphatase will go up again. And secondly, if you get a liver directed UST, you will see no pneumobilia. If the stent is patent, there will be pneumobilia. I mean, there will be air in the IHBR. When the stent is blocked, there will be no air. So, yeah. Please, Dr. Akash, you can go ahead.
Yeah, Swapnil,
Yeah,
move ahead
so
now.
I think we have already discussed the case of locally advanced gallbladder cancer, and the idea purpose of this case was to discuss mainly around the role of biliary drainage. And so the after doing the biliary drainage and the bilirubin levels coming down, patient was given neoadjuvant chemotherapy 4 cycles, and there was a partial response was seen. Now, after response evaluation, what we think that the surgery would probably require a right extended hepatectomy and with bile duct expulsion with hepatocytostomy. So, we've already discussed around the role of in the previous case around the role of major resection And in this case, the patient was actually, I think, fit and was offered surgery. And but yeah, that's it about it. So that's it from my side. I think any more pending questions, examiners can avoid.
Thank, thank you, Dr. Swapnil. I think it was a very well moderated session, and congratulations to both the candidates for answering really well. We will now move on to our the next, second part of our webinar, which is the expert talk by Dr. Akash. I hand over the screen sharing rights to you. Please share your screen and start your talk, sir.
So is my screen visible?
Yes, sir.
Fine. So uh, begin and mind me if I exceed time. So thank you everybody. Thank you ISA leadership and everybody. So I'm going to speak about gallbladder cancer, and gallbladder cancer is pretty common in North India. And before I begin speaking, we are always very frequently asked about evidence, and do I end up asking people, what do you think is the evidence for this, evidence for that? And it's a pretty tricky question at times. So what I'll do is I'll just take a couple of minutes and just go think. So what is evidence-based medicine? So a consultation, explicit and judicious use of current best evidence in making decisions about the care of an individual patient. Now, it has some important components. What it is a consultation decision. It is a carefully thought about decision. It's a clear thing. It's explicit, and you need to, it has to be thought of in different contexts, especially when you're taking about an individual patient, because whenever we are taking patients, so it's not a collective thing, it's more about individual patients. Every patient has their own different needs, requirements, and issues. So if you put it in a Venn diagram, so what we generally talk about evidence is basically scientific evidence when we're talking about. But what we actually need is to integrate scientific evidence with clinical expertise and experience, along with patient preference and characteristics. And when we join all three, that is what is truly evidence-based medicine, rather than only relying plainly on scientific evidence. So why I'm telling this is because gallbladder cancer is a good example of the lack of evidence in a lot of things. So there, other things come into play. It's more of a lot of clinical expertise, your experience, as well as patient preferences. So it's actually evidence-based medicine is, again, it's like an art. It's like riding on two horses together. And this is what David Sackett had to say. He's one of the of evidence-based medicine, that without clinical expertise, practice risks becoming tyrannized by evidence. For even excellent external evidence may not be applicable, inapplicable to or inappropriate for an individual patient. On the other hand, without current best evidence, practice becomes very risky, and it can become out of date, and it can be actually be detrimental to the patients. So with this, I'll just start off. Epidemiology is pretty clear that it is one of the commonest cancer in North Indian females. India, along with Peru, has one of the highest incidences worldwide. Also, other South Asian countries. And recently, there's been a surge of interest. If you look at PubMed, look at gallbladder cancer research. So over the last 20 years or so, there's been a rapid surge in evidence. And as I said in the previous slide, there's very little hard evidence management strategies, because they're based on not many RCTs. Even the RCTs have got a lot of limitations. So that's where the clinical expertise and patient factors come into play in gallbladder cancer. So what we know is that India has got a very high incidence as compared to the rest of the world. Even in India, North India has got a very high incidence, very different pattern as from the rest of the country. When we talk about the New Delhi cancer registry, it's got the fifth most common cancer among females in this area. And probably it's much more common than thought to, because cancer registries actually are able to capture only that much. And there are a lot of underserved areas in North India which are not captured. So what I thought of was that these are the questions which actually most of them are addressed to, but I'll just try to reiterate these things. These are the possible questions I could think of, and what I've tried is try to give a concise answer to these questions as much as I can. They are, of course, gray areas. So I'll take up these questions one by one, and we'll start off with what is incidental gallbladder cancer. So, incidental gallbladder cancer is histological surprise found during a histopathological examination of a gallbladder specimen done for a presumably benign disease, probably gallstone disease. There is no preoperative or intraoperative suspicion, and this has been used, incidental gallbladder cancer has been used very loosely to allude to all post-polycystic gallbladder cancer, which is not absolutely right. That's how things are. And what is not incidental gallbladder cancer again? So it is when you have a suspicion of use on an ultrasound, suspicion on any preoperative imaging, MR, CT, whatever, or you have suspicion at time of exploration. These are better classified as missed gallbladder cancer rather than incidental gallbladder cancer. Next, we come to staging. So, what all can we use to stage the disease? So, we have the standard options. We have a CT scan. They can be, of course, you can do a thorax, abdomen, pelvis, or you can do you can also use an MRI. You can use a liver-specific MRI. You can do an MRCP to see the biliary anatomy, liver blockage, and you can do a PET-CT scan. So, there was during the case discussion, we did see that there was some evidence that PET-CT was routine scanning. So, this is a paper from TMH from Dr. Goel, and he says that there was a 30% change in skin by adding a PET-CT scan. That's impressive. 30% is actually a huge number. Now, when we look at numbers in both NACT group and the non-NACT groups, there was a 60 to 70% operability. 60 to 70% of patients who were judged to be operable by CT scan were actually turned out to be, or by a PET CT scan, were actually operable. I just looked at my data. I did this thing about a couple of years back, and what we saw, we started using, we had them started using a synoptic reporting format, and we compared with the conventional reporting format. So what we found that our patients, when we use the synoptic reporting patients, we were able to predict operability in 86 patients. And even with conventional reporting, we were able to predict 81 patients, which actually also included a sizable number of locally advanced patients. So what the message is that PET-CT is giving us something like 60 to 71% operability. Conventional imaging can also go up to 80 to 85% operability. So the thing is that if you don't have a PET-CT, does not mean that you cannot, stage the patient accurately. Good reporting and good scans can actually, to a great extent, recommend need for a PET-CT scan. And as we discussed that when patient has inflammation, then it might actually not be useful, or it might actually otherwise be counterproductive to use a PET-CT scan, because then you actually end up on a wild goose chase. You see a node lighting somewhere, and then you want to do a imaging, or you want to do an image-guided FNAC or a biopsy, and then it becomes a nightmare. You on a wild goose chase, and you also need to look at logistics. You need to look how patients are. What is the availability of PET-CT scan in your setup, in your city, in your hospital? How much does it cost? And what is the wait list? Because at a lot of places, at least now it's reduced, but a lot of places there was a huge wait list for PET-CT scan. So you can do either of them. So if somebody asks in the exam, so this is why I made these red pointers. So I think they are sort of more key points which you can take home. That if in the exam you can answer you want a triple phase CT scan abdomen, that's fine. If somebody says you want to do a PET scan, yes, we can do a PET-CT scan. We should do a PET-CT scan, but we should understand its potential benefits and limitations. It can help you upstage, tell you about stage, but it can also lead you into undecisiveness. What about staging laparoscopy? So staging laparoscopy, if you're doing very simple staging laparoscopy, that by that I mean we just do a single port staging laparoscopy. So it's not a cumbersome process. It does not take a lot of time. So I think it should be done. This is one paper from GV by Dr. Anil Agarwal. So What he showed was there was a 23% reduction in laparotomy. However, 31% was still inoperable. And that was because of distinct disease rather than uh, local disease. And this is one of the things one should be very clear that despite staging laparoscopy, there is a chance that we might be getting disease which is advanced. In my experience, most of the times which we find the problem is local inoperability rather than distant metastasis. But to sum it up, yes, we should do staging laparoscopy. It's not a big procedure. It helps us to do futile laparotomy. And there's a different ways how much one would do. Some people would even do a staging laparoscopy that would include a intraarticular lymph node sampling. But if I just stick to the basic staging laparoscopy using one or two ports, then I think yes, it should be done. So I think for the exam point of view, one should answer yes, staging laparoscopy should be a range of role of biomarkers. So there's a lot of talk about biomarkers. In fact, we did some research on this. So commonly used biomarkers are CA99, 24, CA2 has come up. Uh, Recently, we did some research on it about 8, 9 years back. Uh, we did for prognostic purpose. But in a nutshell, if you don't do it, it's all right. I would say no, there's no role in diagnosis, prognosis, responses, and monitoring differences because uh, the way they fluctuate over time is also very variable. So I think there is no role of biomarkers. So if you say that there's no great role, I think you will be not judged wrongly by that. Port size revision we just discussed. So Dr. Batra made an interesting thing that if you would like to extract the extraction port, which is actually a good idea. But as far as literature says, and common clinical practice, there was a time when we used to do port site revisions, but not anymore for the last maybe a decade. So if somebody asks, would you like to do a port site revision? The answer is it's not needed. Inter-aortic lymph node sampling. So yeah, inter-aortic cable lymph node sampling, as we have discussed during this case, is an indicator for distant metastatic disease, and intraoperative frozen section should be done wherever the facilities are available. At times, there might be a possibility when you will not have intraoperative frozen section. So then you might use the clinical judgment or whatever. So from the exam point of view, yes, if intra-aortic cable lymph node sampling should be done, yes, it should be done. There is uh, thoughts about it. Another thing that what happens if you have a resectable disease with the intra-aortic cable lymph node, we are not discussing it. It's a tricky thing. So now, what is radical cholecystectomy? If you want to define what are the components of radical cholecystectomy, so a radical cholecystectomy is an en bloc resection of segment 4B5 of liver along with GB and a lymphadenectomy. So we'll come to each of these. Before that, we'd like to go to defining what is extended cholecystectomy. So there was for a long time there was a debate. Some people call it a radical cholecystectomy. Somebody call it an extended cholecystectomy. So now, moreover, the nomenclature is pretty clear. So what extended cholecystectomy means that when we do anything apart from a regular radical cholecystectomy, that is, if you're doing anything beyond a 4B5 with GB and a lymphadenectomy, and we're removing anything apart from that, then it's called an extended cholecystectomy. So what that could be? It could be removal of colon, duodenum, bile ducts, anterabdominal wall, pancreas, doing major hepatectomies because of vascular involvement of the right hepatic artery or right ducts, right 3/8 type block going into the disease going into the right secondary confluent, or there can be a fairly large liver involvement that would require a formal extended hepatectomy. Or there can be a combination of these. One might actually uh, uh, just need to do a colon and a duodenum or a colon with a bile duct. So any combination of this. So this is what is known as an extended cholecystectomy. So this is a frequent question and class today also, how much liver to remove. So you can do an anatomical 4B5 using Wilsonian approach where you take the vasculature in first, You can do an anatomical non-glistening approach where you just remove the 4B5 and take the pedicles as they come, or you can do a wedge with a 2 centimeter margin. All things are acceptable. They're all the right answers. There is no wrong answer in this. As I mentioned previously, the most difficult part is actually to take a wedge. Oh, it's just shifted. Sorry. So in this area, where the hepatic hilum is, you can see the pointer. This is where a 2 centimeter margin is practically impossible to take, especially in cases of gallbladder cancer neck. Mostly in most bodies also, there isn't 2 centimeter to take over there. So you take whatever is available without damaging the infrastructure. So as far as the exam answer goes, at least 2 centimeter margin is sufficient. You might choose whatever you might choose to answer whatever you feel like according to the uh, whatever institutional preferences, your unit preferences you have. A little word about how would you like to do a liver resection? Any technique is better than other? No, they're all good. Whatever you do best is good. You can do cheliclysis, you can do a water jet, you can do a CUSA. They all have their slight benefits, slight disadvantages. But if you are constrained, if you have constraints of resources, cheliclysis works wonderfully. And if you have all the guys in the world, CUSA will work. CUSA will be a bit slow, cheliclysis will be fast. There'll be a difference in bleeding. But all in all, there is no way to say which one technique is better than other. So how do you want to remove liver? You just say the way you do it in your institute. So what are nodal stations to clear and what is the minimum number of nodes is a common question. So as was pointed out, you remove the common hepatic artery nodes, you remove the station 12 nodes, the station 13 nodes, and the minimum 6 nodes should be removed. So exam answer, minimum 6 nodes should be dissected, station 8, 12 and 13 should be removed. A role of adjuvant treatment. This is where things start getting difficult. This is where there's a lot of gray areas. So this is one of the most quoted study, the BILCAP study, and actually it had a lot of biliary tract cancers and gallbladder cancer, a very small fraction of them, and they were not powered to see a difference in survival as far as gallbladder cancer is concerned. However, now when we look at these survival things, survival curves, so when they did it for an intention to treat population, there was no significant difference in using capecitabine in observation at 2 years of follow-up survival is concerned. However, when they did a adjusted per protocol analysis, then there was a statistically significant difference favoring capecitabine in the as the adjuvant treatment in gallbladder cancer. So this is probably one of the most defining studies in as far as adjuvant treatment in gallbladder cancer is concerned. Though it has two important problems, it had very few number of gallbladder cancer patients, and it did not show a benefit in the intention treat population where it was intended to actually see a difference. However, numerically the differences were pretty good, and so when we look at this is a basic you know summary of what all trials and studies which we have in gallbladder cancer. Basically, most of these are having all biliary tract cancers, that includes cholangiocarcinomas, and it is pretty clear till by now that all biliary tract cancers do not behave similarly, and gallbladder cancer is probably one of the most aggressive cancers. So, however, whatever knowledge and whatever information we have at the moment, best use of it. So there are two studies which show benefit in survival. One of them is the BILCAP study, which we already had. Numerically, very high difference in survival. It's a good numerical advantage. When we look at the JCOG study, where they used S1 against a control arm of just observing patients after surgery, this was again showed a survival benefit at 3 years. Apart from this, we have 4 other studies, including one study from GB Pant, which was actually exclusively for gallbladder cancer. It had its own issues, but nonetheless, none of these studies which have used gemcitabine oxaliplatin, gemcitabine alone, or gemcitabine with cisplatin have shown any difference in survival, recurrence-free survival, or overall survival as compared to observation alone. One of the most important studies which has not yet come out is the ACTIVA trial, which initially was planned to study gemcitabine to observation, but after the publication of BILCAP, capecitabine was taken as a control arm and it had to be reset. So, awaiting this trial, as of now, the best evidence is using of capecitabine. What about adjuvant chemoradiation? So, there are no randomized controlled trials. What we have is few the SWOG study. There's a multi-institutional retrospective study using 3 arms chemo-RT versus observation, and then the Mayo Clinic experience. All of these have shown benefits of adjuvant chemoradiation, but again, these are small studies, and one is not translated into clinical practice. So, as adjuvant treatment is concerned, the exam answer is, I mean, you can be very certain say, exam answer, capecitabine is the treatment of choice. There's still not great evidence supporting this, but a lot of people use it. We have used it for years, and it's fine. So if somebody says, if your institution says GEMS is better, yes, definitely, that's a good answer. Chemo-RT, one should not say that's the treatment choice because there's practically very little evidence. Okay? One of the things about capecitabine is, and why people are very afraid, is as Dr. Salman said, it's a pretty high dose. We don't give the 1000 mg per meter square per dose thing because the dose here is 1250, and it's a very difficult dose for patients to tolerate. Especially our patients with a lot of hand-foot syndrome, and a lot of our patients actually end up having dose reduction to the extent that we actually have to take them off capecitabine and shift them to gemcitabine cisplatin, gemcitabine oxaliplatin. So, things to know is that capecitabine is the first choice, but then it has got a lot of toxicity, and that leads to suboptimal dosage and suboptimal treatment. So, one should be a bit aware of its toxicity. Next, another difficult thing: what is locally advanced gallbladder cancer? So, it's fine. It's a T3N plus disease is locally advanced gallbladder cancer. The problem is, when is it T3? On imaging, on laparotomy, or on histopathology. So this is where things get very difficult. And because staging is a challenging gallbladder cancer, it's a small space, multiple structures, adhesions, inflammation, and radiological assessment is even surgical assessment at times is very difficult. So why is it difficult? So I'll just give you a snapshot of data which I had collected, which I had presented a couple of years back, maybe more. So it is how things change from imaging intraop to pathology. So we had 86 locally advanced gallbladder cancer according to images. And in this locally advanced, I am not taking any N. I'm only talking about adjacent visceral involvement. When we did a laparoscopy or a laparotomy, 19 of found to be metastatic, 37 found to be locally advanced, and we found 30 early disease. So this is how now from 86 we have gone down to 37. From early disease, 9 did not have a malignancy at all. 21 had actually early disease. From locally advanced, again, when we did intraoperatively, we did a resection, we did other visceral resections. One patient did not have a malignancy at all. 10 had malignancy, but there was no adjacent organ invasion. And malignancy along with adjacent organ invasion was present only in 26. So now when you look, out of 86, which were locally advanced on imaging, 20% were metastatic in the first place. 30% had early disease, and only 50% had locally advanced in surgery. So from imaging to surgery, we are coming down at 50%. Moving further, 25% actually did not have any adjacent organ invasion. So at the whole picture, only 30% of the patients who had locally advanced gallbladder cancer on imaging actually had adjacent organ involvement. So that's a big fall in number. So what we consider as a locally advanced gallbladder cancer in my scenario as far as adjacent organ involvement is concerned, it's pretty different. It's only 30%. So that is a huge change, and it has got major implications. Implications as in, what about NSCT and NSCRT? So the philosophy is to control micrometastatic disease and to also reduce, not actually under downstage, but downsize towards more, because tumor which is uh, stuck to the, which is involved the duodenum will involve the duodenum, but the bulk might reduce. So involve the colon will involve the colon. I mean, it's very difficult that it will go away from the colon. But then it has its own limitations as an incorrect staging. And with incorrect staging comes to difficulty in attributing treatment effect. So, and I'll just show it. And another problem is that gallbladder cancer is generally poor response rates. So in this case, if I had taken my set of patients and I had ruled out of the 86% patients, metastatic patients completely by doing a staging laparoscopy, leaving a locally advanced, and of course no malignancy patients as off. So we would still be actually having only 44% as locally advanced. So that is, we are actually overstaging 50% of the patients, which is a serious matter. And that is where the implications are, that do you attribute uh, the the need to do lesser number of multivisible resections, or uh, when you see that the corona, do you attribute it to actually chemotherapy or whatever neoadjuvant treatment, or to something else? So this is a paper from TMI, it's a very frequently quoted paper, and there you see 30% of patients actually were not able to receive any sort of surgical treatment, and of those who were able to, only 40% resectability rates were there, and 60% of patients were potentially curable and probably had some survival benefit, did not understand. This is one of the things with neoadjuvant chemotherapy, that we are not able to, especially gallbladder cancer, because proximity of multiple organs and difficulty in actually finding out invasion. This is again Dr. Goel study. So where, if you can see, when we have seen all the patients who underwent NACT, and of all the patients who have undergone NACT, we take this 34, only 16 were able to undergo surgery, which is actually a pretty small number. And more importantly, 38% patients did not benefit from chemotherapy. So that's another big problem. So in a whole, only 10 out of 50 patients were able to undergo curative surgery. So this is like how one can also think on lines of chemotherapy. Whether do you think we would want to choose these super selective in these patients, or would you like to offer chemotherapy to a greater number of patients? Surgery to a greater number of patients. So my exam answer would be that there is no strong evidence to support use of neoadjuvant chemotherapy or neoadjuvant chemo radiation. My personal policy is that I would operate upfront all except patients with jaundice or bulky nodes or vascular involvement on imaging. And whenever one would embark on a neoadjuvant strategy, whatever be it, so I think it's always judicious to do a staging laparoscopy, because by doing staging laparoscopy alone, you would be able to remove a lot of patients who would otherwise actually turn out to as being as poor responders to, or non-responders, which would label as actually progressive disease to chemotherapy, when actually it might not be a progressive disease at all. Jaundice and gallbladder cancer, this was the last case which we had discussed, and is one of the most trickiest things to encounter while we are talking about gallbladder cancer. Generally, CBD calculus can be one of the reasons for jaundice, Marie syndrome, but by far the most common and most difficult to manage are malignant obstructive jaundice. So this is what small data from my experience over the last maybe 4 years or so. So we looked at what was the cause of blocks in patients of jaundice. So primarily it was the primary disease which was causing jaundice, infiltrating the hilum. Less frequently the nodes, rarely the stones. And when you look at levels of drug, so what we do is we use the Biswas classification of perihydral block. So a majority of patients actually had a level 1 block, that is just distal to formation of confluence, or level 2 blocks where the two left and right ducts are separated. And drainage in these patients is difficult because the level 1 blocks are also pretty high up, and ERCP is at many times not feasible or does not take care of the drainage. A lot of meningitis does occur. So gallbladder cancer with obstructive jaundice is a nightmare. It's a challenge. And I could identify these things. Operability of stage is a problem. Serum bilirubin is a problem. Liver is a FLR. Do we have enough FLR to tolerate a hysterectomy in the patient who has got jaundice? Most of these patients which come to us are pretty run down. They have a lot of nutritional issues, financial issues, because I work in a large public hospital where money is an important thing. And then there are also issues related to technical expertise and infrastructure. So if we just remove these last 2 points, because most surgical oncologists would have technical expertise and the infrastructure to support it. So we looked at some of our data and we found that 69% were actually metastatic. So yeah, there is evidence that says that gallbladder cancer is not a jaundice is not a contraindication to surgery in gallbladder cancer. But then a huge number of patients are upfront metastatic. So we are left with very few non-metastatic. Serum bilirubin RCs was something like 14 milligram percent median, ranging from 3 to 38 milligram percent. So that you see that it takes a long time for this. And a lot of patients who actually had liver, we were able to normalize liver. We had a lot of encountered a lot of problems with small FLR should not sustain a patient. Nutrition and finance remain a problem. So nihilism in gallbladder cancer with obstructive jaundice is not completely unjustified. Whoever has experience would agree with me that the recurrent cholangitis, there could not PTBDs. So all not a great scenario. However, there are some promising reports from GB Pant, Dr. Agarwal, and Dr. Goel and Shraddha from TMH, which actually shown good results in patients with of gallbladder cancer with jaundice. For us, in our place where we stay and serve, it's not a great disease to have. So this is my last slide. So this is how things are in exams nowadays. So examiners and other spectators, juniors, seniors are there to see. And the examinee has got a spade in his hand and he's left to dig his own grave. And now new NMC rules. There's an NMC photographer also who is there to record things for posterity. So that's about it. If there's a question answer session, I'm happy to take questions. Thank you.
A great expert talk, Dr. Akash Agrawal. I really enjoyed how you chose with a separate font to include exam answers for our examinees. And I think that bottom line for most of the subparts of this topic, where there is confusion, I think you have given a good, clear indication of what the student should take back from this talk. Really, thank you for that expert talk.
Thank you.
Now, the third session, part of this webinar is the Q&A session. But I think the discussion today, which was so much in detail, thanks to Dr. Swapnil and Dr. Tarun and Dr. Akash, I think we addressed most of the Q&As. The only thing I find myself having to ask the examiners is to give an answer on the question that was posted to the examinees, which was on the cutoff for a completion cholecystectomy after an incidental gallbladder cancer. I think there was a discussion between 12 weeks, 3 months, 6 months. So is there an answer for that, Dr. Tarun or Dr. Akash, whoever is there? Is there an answer for that question, and what is that answer?
I don't think there's an answer.
Yeah. Tarun sir, you?
I don't think there's any evidence on this, but I'll just tell you what we practice because one odd patient you will see.
Yeah.
You will see one odd patient who will say that he got a lab fully done maybe 6 months back or a year back. So usually here, if it's more than 6 months, we don't operate. We get a PET scan done, and if nothing lights up on a PET scan, then we just observe the patient. But
Perfect.
rightly so, as Dr. Akash said, that I mean, if you have to make an error, it's better to operate. It's better to operate. It's completely a personal decision or institute's choice.
Another, I think on YouTube we have that question asked. I think we have Dr. Akash Agarwal who's from RML Lucknow. So did we discuss about the Lucknow technique? What is Lucknow technique and what should the students know about that?
I'm ashamed to know that I don't know the Lucknow technique, but honestly, I don't think there's, and I've studied Lucknow enough to know that I don't think there's a Lucknow technique.
Okay.
Somebody
Tarun?
knows, I'll be happy to know about it.
No,
Yeah,
neither
Dr.
do I.
Tarun, anything from
No,
you?
no, 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 no. Neither
Perfect.
do I.
I think then we leave it at that. I think whoever asked that question can yeah, Google it and maybe tell us if they find an answer to it. Right. This brings us to the conclusion of tonight's webinar. We have two upcoming ISO academic sessions. First on April 29th, which would be the practical aspect of today's topic, which would be the mastery of surgery on gallbladder cancer. And we'll have three interesting talks in that. So whoever is there, to the end of this webinar, we request all of you to kindly join us 7 p.m. 29th April. And I think we'll just continue this discussion and go into how to image the liver and gallbladder for surgical planning. And that will be followed by video tutorials on radical cholecystectomy, non-anatomic and anatomic liver sections. In May, we'll be having a masterclass and mastery on another subject as well. We would like to acknowledge the presence of Dr. Sharad Desai, ISO President, Dr. Rudra Acharya, ISO Secretary. The section of Dr. Rudra Acharya was supposed to give the vote of thanks, but I believe he has messaged that he has to join an emergency surgery. So on their behalf, I would like to thank the examiners today, Dr. Akash Agarwal, Dr. Tarun Batra, and Dr. Swapnil Patel for their time. It's not just the 2 hours here. The preparations for this session goes 2 to 3 weeks in advance. A lot of things are discussed before these scenarios are carefully curated and put up. Both the examinees, we thank you for your participation. I think we have Dr. Sharad with us now. Sharad sir, are you there?
Yeah, I'm there. I think we complete the thing because unfortunately, I'm sorry everybody that I missed joining in the initial part because of a surgery again, emergency. Thank you, Srijan, and thank you all the panelists and the students for attending this session.
Right. On that note, I think we'll conclude today's webinar. Thank you all for joining in. Wish you a very good evening, and we'll see you all again in 2 weeks' time. Thank you.
Thank you. Good night.
Thank you.